Good afternoon, everyone. As Professor Hackett is going into presenter mode, I'm going to start with his introduction. Professor Jeff Hackett, he is a consultant and professor of sexual medicine and diabetes at Aston University in Birmingham, UK. He did his medical school in 1974. And has worked in the association of erectile dysfunction, cardiovascular disease, and type 2 diabetes with multiple publications since then. I believe he has over 160 publications, multiple book chapters, as well as books. And in addition to these, he has also been a lead author on the consensus guidelines on erectile dysfunction and cardiovascular disease from the British Society of Sexual Medicine, as well as Princeton 3 guidelines. He is the past president of the British Society of Sexual Medicine and has served in leadership in various societies since then, including being on the board of directors for the Androgen Society. So today's topic is a deep dive into the role of testosterone therapy in men with pre-diabetes and obesity. So thank you so much for joining us, Professor Hackett. You can take it from here.
Thanks very much, Sandeep, for that kind introduction. Right, now I've got a series of case histories. This is episode 4. It makes it look pretty impressive. This is I'm going to start with a patient called 𝗣𝗿𝗶𝗯𝗲, who I've been looking after recently. And Sandeep mentioned books. There's one that you might like to look up that is published a couple of years ago, Testosterone in Cardiometabolic and Other Diseases. Right. So just to set the scene, testosterone is a very important hormone in cardiometabolic disease. It's associated with low testosterone is associated with poor cardiac health and increased risk of myocardial infarction and stroke. But today I'm specifically focusing on the metabolic aspects, and particularly insulin resistance, type 2 diabetes, and CKD and anemia, which commonly coexist with type 2 diabetes. But we must not forget that there's important psychological and cognitive changes, physical symptoms, and I'm going to say quite a bit about visceral obesity, and also the sexual symptoms, which are actually what most commonly bring the patients to see us. So I'm focusing on the metabolic aspects today. So let's get straight off with the patient. This is 𝗣𝗿𝗶𝗯𝗲, who I first saw in 2021. He was age 45, a senior financial advisor, 2 children, recently divorced. And it seems that with all my cases, I only ever see them when they've recently been divorced. I wish I could see more men before their first marriages or even their second marriages failed. So he presented he'd had ED for 4 years and he'd been on sildenafil from his GP, 50 milligrams PRN, which hadn't really been effective. His BMI was 32, so he was moderately obese. He'd been gaining weight and feeling increasingly lethargic, exercising less, and he was finding his job more stressful and not really coping. He had a slightly elevated blood pressure, and when we did his blood test for testosterone, his testosterone level was 8.5 nanomoles per liter. Now, I know you think in US units, and I always remember that 300 nanograms per deciliter equals 10.4. So this is definitely low. Normal SHBG, lowish free testosterone, low normal FSH and LH. And he was told by his GP that these results were normal. Now, that's something we might like to talk about because GPs often refer to reference ranges from labs, which merely tell you where 95% of a normal population fall, where we should be following guidelines for treatment according to evidence-based guidelines from societies. He had an abnormal lipid profile with a raised total cholesterol, lowish HDL, raised triglycerides. He also had pre-diabetes with an IFCC of 45, so anything over 42 in the UK is regarded as pre-diabetes, and he had a reduced EGFR, so he had mild CKD. Most importantly, both of his parents had had type 2 diabetes, plus his older brother, and his father died of an MI at 60. So there's a pretty bad family history there. So he has metabolic syndrome, prediabetes, dyslipidemia, high risk profile, secondary hypogonadism, ED, unresponsive to on-demand therapy. He also suffered from some premature ejaculation. He totally lost all morning erections and his libido was very low. And as I said, he'd had a poor metabolic family history and he'd failed with multiple attempts at lifestyle change, and his work and his family life had been really severely affected. So he was in a new relationship following his divorce with Sunita, and she was younger, 35, and wanted children. Less sure, but as usual, the lady wins the day. I commenced him on tadalafil 5 milligrams daily. I put, of course, because when patients have failed with on-demand, and particularly when they're in new relationships, and particularly when they've lost their morning erections, they need to be on daily treatment. We treated his blood pressure with ramipril. We gave him rosuvastatin, which we had to increase to 10 milligrams. Now, I chose to put him on clomiphene 25 milligrams daily because of this desire for a further child. I warned him that the response tended to be less in older men, particularly over 50, but he should be okay. When we did the blood test shortly afterwards, as we often see, his estradiol level went up from 180 to 300, and he also got reduced libido at this time. So we put him on a small dose, a very small dose of anastrozole twice weekly to get the estradiol down. After 9 months, he announced that Sunita was pregnant, and he said that he wished to go on to proper TRT at that time. So we discussed what to give him, and at the time in the UK, it was a matter of either testosterone gels or injections. He decided on gels because at that time there was not much cooperation from his primary care physician, and he was demanding a shared care protocol with his NHS hospital, and this would have demanded a long waiting time. We love waiting for things in the UK. So by this time, Sunita and 𝗣𝗶𝘳 now had a healthy son, so we commenced him on testosterone gel, Testogel, 2 pumps daily, and this replaced both the clomiphene and the anastrozole. In the short term, he asked if we could increase the tadalafil to 10 milligrams daily, which we agreed. When I last saw him in December 2025, there'd been something of a transformation. He felt relaxed and well. His job and his family life were going well. He'd started going back to the gym regularly. His BMI was down. His blood pressure was down. His testosterone levels were 18.5 and 20. His free testosterone was normal. His lipids had improved. His IFCC had come down from 45 to 40, so he was no longer in the pre-diabetic range, and his eGFR had gone up to healthy levels. So his metabolic profile was much improved. We'd reversed his pre-diabetes and reversed his CKD. So the question I'd ask is, if we were clients of 𝗣𝗑𝘳, would we prefer to have the 2021 version or the 2025 version as our financial advisor? Because so many of our patients that we see do actually very important jobs, and we need to recognize that when they begin to lose control and feel tired, they do their jobs less well, and their marriages often seem to fail right before their eyes. So, what's the evidence that testosterone therapy will improve diabetes control? Well, we've got 3 main studies here. We've got the T trial that was done in 2017, which is quite a small study, but very positive, and that used testosterone gel, 1%, and the cutoff there was 10.4 nanomoles per litre, or 300 in your units. And then we had on the right, the T4DM study, which was a study done in Australia with the primary endpoint was to prevent progression from prediabetes to avert diabetes. And this used testosterone undecanoate, long-acting injection. But the cutoff there, interestingly, was 14 nanomoles per litre. And we'll talk a bit about that trial later. That trial had a very active lifestyle intervention, whereas the Traverse didn't have a lifestyle intervention program. Now, when we talk about each of these trials, I'm going to point out that in the combined trials, only 4 to 8% took a PDE5 inhibitor at any stage in these studies, and I'll elaborate on that a bit later. So if we concentrate on the T4DM study, because this was the one that specifically looked at progression from prediabetes, clinical diabetes as its major endpoint. This had 1,007 men, and half were randomized to either 12 weekly testosterone under canoate or placebo injections, and it was a 2-year study, and the endpoint was the number of patients who developed type 2 diabetes over that time, as measured by fasting blood glucose, not HbA1c. They chose fasting blood glucose, and I'll elaborate on that a little bit later. Their finding was that there was a 41% reduction in progression to type 2 diabetes, 12.4% versus 21% in the placebo group. And that effect was there in the ones with prediabetes, and there was also an effect of reversing type 2 diabetes in the patients who turned up to be newly diagnosed at baseline. Now, just a reminder for you why this is important. What we know from the 𝗂𝗵𝗔𝑆 study, a landmark study many years ago, that each 1% reduction in HbA1c reduces diabetes-related deaths by 21%, MIs by 14%, and microvascular complications by 37%. So it's really quite important. Now, this talk is about weight loss. So here are some secondary data from that study. And as you can see, in blue, we've got testosterone, and in the pale green, we've got body weight. So patients on testosterone lost around about 4 or 5 kilograms. And remember, they had a lifestyle intervention. So the patients who were put on diets did lose some weight on placebo. The waist circumference went down more with the testosterone, but the patients on the placebo lost some muscle, whereas the patients on testosterone gained muscle. There was an increase in there was a bigger decrease in total fat mass with testosterone, a bigger decrease in abdominal fat, and the patients gained arm strength and grip strength when they took testosterone therapy. The effects on sexual function are modest, and this is very common in testosterone studies. You get small improvements in erectile function, general small improvements in desire, orgasmic function, intercourse satisfaction. And interestingly enough, 40% of these patients in this study had significant LUTs, which is why I'd raised the point, why was such a small number on treatment for it, and wouldn't a PDE5 inhibitor have been useful for that? I'll now move on to my own study, which was the BLAST study, which was at that time the largest was done in established diabetes. Now, we screened 856 patients with type 2 diabetes in general practice to get 200 patients, and we allocated 100 to testosterone injections, testosterone under canoate every 12 weeks, and the other half, 100, went on to placebo injections. And the treatment effect that we saw was a reduction at 30 weeks, which was the double-blind element of the study, of 0.41 in the A1C. They lost a bit of weight, their BMI improved, their waist circumference fell a bit, their total cholesterol fell a bit, their erectile function improved a bit, their aging male symptom score improved a bit, and their depression improved a bit. And 46% reported a general improvement in their health. In an open label study of a further year, those benefits improved. So we went up to 0.87. The more weight was lost, the BMI got even better still, more improvement in waist circumference. But if you look at the erectile function, that improved, but it improved enormously in the men who were taking PDE5 inhibitors. and highly significant p-values. Another important finding was there was no response in the men. 23% suffered from depression. So testosterone seemed to be less effective in men who suffered from depression. And in our study, 26% were taking a PDE5 inhibitor. Hence, we got the better improvement in erectile function. When we followed them up, we looked at mortality data. And it was quite striking because we followed them up for 4 years, and there were a large number of people. And what we showed was that the patients who were the blue, you have the eugonadal untreated, the green, the hypogonadal untreated, and the reddish, the hypogonadal treated. And as you can see, significantly fewer people died. And the greatest effect was seen in the older patients, particularly the 70 to 80 years old. And these were patients not receiving a PDE5 inhibitor because there was a separate benefit from taking a PDE5 inhibitor. This was to isolate what was purely due to the effect of testosterone. Important message here is the greatest reduction in mortality was seen in the older patients. Just to mention, because in a couple of weeks' time we go for the Androgen Society meeting in Chicago, and in 2012, where I first presented this data, we actually won the ISSM Zinyotti Award for research, and that was in Chicago. So it just seems interesting that here I am presenting this, and I'm doing a presentation in Chicago, and it's 14 years on. Now, moving on to the TRAVERSE study, which is the largest study ever done on testosterone replacement therapy. 5,204 men reported in June 2023. Now, here we're considering tonight metabolic disease and type 2 diabetes. So first point to make, in TRAVERSE, 70% of patients already had either type 1 or type 2 diabetes. And that was something that was not really adequately discussed when the paper came out. Now, I'm now going to report on a secondary paper from TRAVERSE, which was looking at this progression from prediabetes to overt diabetes. And as you can see here, this highlights the numbers and the percentage of men in both the testosterone group and the placebo group who went from prediabetes to overt diabetes over the course of the study. And as you can see, by 24 months, it looks as though there's been a significant change. But as the numbers dwindle later on, you can see the significance is lost a little bit. But interestingly enough, the progression to type 2 diabetes in this study was not based on fasting glucose. It was primarily based on the HbA1c reaching 6.5 or greater, or the initiation of diabetes medication. And in fact, the authors in the discussion say that they were actually the major reasons why patients were classified as converting, because it became very difficult to get numbers of consecutive fasting glucoses the longer the trial went on. Importantly, this is a lower rate of progression than would be expected in other studies, because other studies suggest that 25% should have progressed, and here we're looking at 16%. So why might that be a lower rate of progression than seen in other studies? I think I have the answer. If you look at this graph here, on the left we have the presentation at the American Diabetes Association in 2023, and on the right, the final publication by 𝗤𝗂 in 2024. And as you can see at the ADA, it looks as though this is significant, a p-value of 0.027, and the most effect is seen at about 2 years. But when the paper comes out and the numbers have just progressed a little bit more, the p-value has now gone to 0.06, and the conclusions seem to be different. Now, I've done a lot of analysis of this paper, and I think I've come up with the reasons why. If you look at the classification of prediabetes, either by IFCC or HbA1c in different countries, you'll see that in the US, the classification of prediabetes is 5.7 to 6.4. In the rest of the world, it's 6 to 6.4. The fasting glucose is 5.6 to 6.9. In the rest of the world, it's 6.1 to 6.9. And I'll emphasize again, in TRAVERSE, only 8% were taking a PDE5 inhibitor. So what this means is that patients in TRAVERSE had to move a lot further in terms of their A1C to become diabetic than happened in the European and UK studies. And if we look at the paper and read closely, we actually see that the mean A1C level was 5.8. Now, that would not have been pre-diabetes in any other country in the world because the cutoff was 6. So more than 50% of the patients in TRAVERSE would not have been labeled as having pre-diabetes in the rest of the world. So they had to move from 5.8 to 6.5, whereas in the other trials, you only had to move from 6.2 to 6.5. So that explains why the conversion rate was so low in TRAVERSE. Also, in relying on HbA1c, we know that it's less reliable in patients with anemia, and 16% of patients in TRAVERSE had anemia. They didn't make any adjustment for that. So there's my point. Men had to move from 5.8 to 6.5, which was a long way to go. Why was the baseline mean at the bottom end of the range? I think it was probably because of a policy of treating patients very early, because once you put them on any form of drug, they were labeled as being diabetic. Now, the other conclusion is these findings suggest that TRT alone should not be used as a therapeutic intervention. But we would never suggest TRT as a sole therapy to prevent diabetes. It would always be combined with diet and lifestyle intervention. So I wrote a paper in the World Journal of Men's Health where I tried to point out all these factors, and it's there if you want to look it up. But it's not really, I think, been generally recognized, particularly this point about the different classifications. So here's a paper that highlights this effect of anemia as the goal of optimal HbA1c control, and it points out that iron deficiency anemia can cause high HbA1c levels. And in all the studies on testosterone, we show that when you give testosterone, you tend to correct the anemia. So that in its own will tend to be causing changes in HbA1c. And it gets more complicated because if you get other forms of anemia, such as with sickle cell disease, blood loss, 𝗬𝗏 in treatment, they can have very complicated effects moving the HbA1c in different directions. Now, moving on a little bit to chronic kidney disease, which commonly coexists in these groups. Here's an excellent paper by Michael Zitzman recently, which shows the heavy impact of chronic kidney disease on testosterone deficiency. On the right, we have the mechanisms by which increased leptin, inflammation, uremic toxins can affect the hypothalamus and pituitary and testis to lower LH, FSH, and testosterone, and the impact of chronic kidney disease on anemia, bone density, sexual function, mental well-being, inflammation, and increased insulin sensitivity. So where does this come into the pattern that we've been talking about? Here's a huge study done by 𝗤𝗏𝗄𝗏 Sharma, which looked at the effect of testosterone replacement on chronic kidney disease progression. And what it showed is that treating low testosterone levels to the normal range delayed progression to end-stage disease by 12 months and significantly reduced mortality. So rather than being a risk in CKD patients, it's positively beneficial. And CKD, as we know, is strongly associated with diabetes, anemia, and osteoporosis. We should really be targeting these groups to measure testosterone. And this is a very recent study that my group did in the UK, where, inspired by what those other studies, we actually looked at over 1,500 patients who'd been coming to a CKD clinic in Manchester in the UK, and looked at those who'd been treated with testosterone and not treated, and we showed a significant reduction in mortality and improvements in eGFR when patients were treated with testosterone therapy, and no adverse effects in terms of MI, prostate-related conditions, prostate cancer, or heart failure. Now, the big thing at the moment with obesity is not to treat obese patients with who have low testosterone with testosterone. It's to give them GLP-1 agonists, and these certainly in the UK clinics are escalating everywhere. But there were some warning signs in the early studies. Here we got semaglutide, liraglutide, and what they consistently showed is that although there was significant weight loss, between 25 and 40% of the weight loss was actually lean muscle. And in the right-hand side, right-hand top, you can see how the green line shows that patients who lost weight with GLP-1 agonists had more loss of lean muscle than those who lost weight through other methods, particularly diet and lifestyle. So there's a warning here, because in these clinics, nobody is measuring testosterone and treating it. And here we see just a little reminder of the effects of GLP-1 on testosterone. They increase total testosterone, but they have minimal effect on free testosterone, because the SHBG goes up as you lose weight, and you need to lose 20 to 30% of your body weight to see a significant increase in free testosterone. And also, we're getting some patients who are complaining of fatigue and reduced libido on these drugs. Finally, I'm just going to say a little bit about PDE5 inhibitors. This is my great mentor, Graham Jackson, unfortunately, who passed away about 10 years ago, who told us the way to a man's heart is through his penis, and that PDE5 inhibitors are important cardiovascular drugs hijacked by urologists. And I think you got the message that in the studies I've mentioned, the use of PDE5 inhibitors was extraordinarily low for men who would have had high rates of ED. And in a landmark study where he put the benefits of PDE5 inhibitors in men with cardiovascular disease, I would just highlight this point here that he observed. In patients with diabetes, PDE5 inhibitors reduced microalbuminuria and lowered glycated hemoglobin, and as a consequence, they would improve and reduce oxidative stress and improve the prognosis in patients with type 2 diabetes. So from an early stage, we knew they were important drugs. Here's a study which lays out the effect of PDE5 inhibitors in type 2 diabetes of improving beta cell function, decreasing liver glycogenolysis, decreasing inflammation, and decreasing mortality and the rates of acute myocardial infarction. And there are several studies now that show that PDE5 inhibitors reduce cardiovascular mortality. Here's a study, a placebo-controlled study, which showed that daily tadalafil actually lowered HbA1c, relatively small study. It also lowered fasting blood glucose in 40 patients in each group. Here's a study recently published in The Lancet, which actually compared long and short-acting PDE5 inhibitors. And this was quite striking. This was on-demand use. And what it showed was that the HbA1c actually increased in patients who were who took PDE5 who took short-acting drugs by 0.36, and decreased in patients who were on long-acting drugs, i.e. tadalafil. And this really called out for a study to look at the effect of PDE5 inhibitors, particularly daily tadalafil, on diabetes. This is an interesting study that came from Japan, because PDE5 inhibitors, particularly tadalafil, have been licensed to treat 𝗏𝗏 BPH for many years now. And this was a study that looked at 20,000 men who'd been on alpha blockers and 5,000 men who were on daily tadalafil. And there was a 53% reduction in incident type 2 diabetes in the men who took daily tadalafil. And this should not surprise us with what we've been saying earlier. So is it any longer appropriate for alpha blockers to be first line in men with 𝗏𝗏 who also have cardiometabolic risk? This study showed that daily tadalafil has significant effects on increasing testosterone levels, a relatively small study, and it did so by increasing LH, suggesting that the effect is by a direct increase in blood flow on the testes. Various review studies have looked at the multiple mechanisms by which PDE5 inhibitors can be beneficial in chronic kidney disease. Here's one, here's another, all calling out for more studies done with PDE5 inhibitors to look at the protective effect and diabetes reduction. And interestingly enough, I've published a paper recently. I collected a series of patients who'd been on regular PDE5 inhibitors and showed regression of diabetic neuropathy. And this is just common sense, because if at least 50% of patients with type 2 diabetes will develop diabetic neuropathy, the ADA guidelines list 5 factors that increase the risk: chronic high blood sugars or HbA1c, duration of diabetes, and poor arterial circulation, as diabetic neuropathy is primarily a microvascular disease. This is what PDE5 inhibitors do. They treat microvascular disease. And I described these cases, and these are the reviews I got when it was published. Reviewer 1, this is a remarkable review about a topic previously undescribed. It makes common sense. Current therapy focuses on medication to block neurological pathways, such as amitriptyline, gabapentin, pregabalin, and opiates. These drugs do not address any of the pathological processes and have multiple side effects, especially sexual dysfunction, cognitive impairment, and hypogonadism, already highly prevalent. Reviewer 2, this is an excellent review of a generally ignored subject with common clinical complications. I have no comments to change or correct. It is well written and comprehensive, and I would urge you to begin to look at this in your patients with type 2 diabetes. So, bringing everything together, PDE5 inhibitors and testosterone therapy have important cardiometabolic effects, particularly reducing type 2 diabetes, reversing anemia, and delaying CKD progression, as well as psychological, physical, and sexual benefits. If you want to look at this further, here are the BSSM guidelines, which I think are the best guidelines on adult testosterone deficiency, and even Abe Morgenthaler lists them as his favorite guidelines. And here are the recent changes that we've made. Based on T4DM, we've suggested treating low testosterone up to 14 in patients with prediabetes. Free testosterone is the best guide to long-term mortality. Use daily PDE5 inhibitors early. Measure T in CKD and in post-COVID patients, which are another group. Measure T levels in patients with anemia of known or unknown cause. Don't forget men with long-term opiates. And also, we now know that DRE isn't necessary because these drugs are safe for the prostate. For the next coming consensus meeting we've got, I was asked to summarize the level of evidence from this review, and I concluded that testosterone therapy to the normal range in men with confirmed testosterone deficiency delays progression of CKD, and it also delays progression from prediabetes to confirmed diabetes, a level 1B, and that PDE5 inhibitors with regular dosing delay progression of CKD 2A level. Regular dosing with PDE5 inhibitors delay progression to type 2 diabetes 1B. And here are some quotes from a prominent cardiologist in the UK. The evidence for PDE5 inhibitors is more convincing than for statins. And this is our professor of renal medicine in Manchester. Wonderful stuff, this tadalafil, he stated to me. Thank you very much. I hope I've generated some discussion. Back to you, Sandeep.
Thank you so much, Professor Hackett, for this clear and detailed presentation. We will open this forum now for questions for the attendees. If you have a question, you can type it in the chat. That's preferred, although there is also Q&A button as well, and you can type it in over there as well. There are no questions at this time, and while they are coming in, I have a couple of questions myself. If you could share your screen again and go to the slide where you had compared the testosterone levels in the 3 trials, T4DM, TRAVERSE, as
Yeah,
well as...
right, let's go down. Okay, where's it gone then? Ah, there we go. So, okay, so I put it onto big screen, right?
We cannot see it yet.
Ah, that was it. That one.
There you go. Yes, we can see it now. Perfect. This one. So
Yeah.
I just wanted to have a detailed discussion about the hormone levels in
Yeah.
both the trials, specifically the TRAVERSE and T4DM. And as you can see in the T4DM, we are starting with higher levels because they included men up till, in our units, 400 nanograms per deciliter. And then we went up quite a bit. In fact, the starting level in T4DM is even higher than the on-treatment level in the
Correct.
TRAVERSE
Yeah.
study. So certainly we can argue that the treatment was suboptimal in the TRAVERSE study as a case. That is number one. But
Yep.
the other point is that really, sometimes we insist on treating only hypogonadal men for their symptoms, but in terms of diabetes, we can, that part really doesn't apply at all. You're basically trying to get testosterone to improve some muscle mass, lose some fat mass, regardless of the starting testosterone level, and it would still work.
Yeah, the point there though is that if you look at TRAVERSE, the blood level was done 24 hours post, so it would have been definitely at a trough level, whereas in the T trial they did 2 hours post gel, so they were almost looking for the peak level in the T trial, and in T4DM it's a trough level, so it's 12 weeks after they had their testosterone undecanoate injection, so those patients were undoubtedly much higher than that throughout the period. The other important thing that there is that in the TRAVERSE study, any study that you do with gel usually has greater compliance issues than those with the long-acting injection for obvious reasons, because patients have to remember to use the gel each morning, and it might not fit in with their lifestyle. And if they're not seeing benefits, they tend to fall off using it. When you have a Nebido injection, which is the testosterone undecanoate, you have 12 weeks of injection, which is given into your buttock by a nurse or a doctor. So there are no compliance issues. You also know precisely what the compliance is because you know that every injection was given. There was nothing that the patient could do wrong. Whereas when you give them gel, there's various ways they might apply it wrongly. They might go swimming or go to the gym or whatever shortly after they've used it. So there's always much more variability with the gel studies.
That is true. Compliance is a major issue. But if you just compare the levels, I guess, would it be fair to say that T4DM also had trough levels and TRAVERSE also had trough levels? So at least in that way, it is not completely apples to oranges, but there is some similarity in terms of the level, final level achieved is clearly low in the Travers trial, which
Yeah.
may which may have played a factor.
And it's likely that it got lower the later the trial went on because the numbers were dropping off as the trial continued. And although we don't have the data, it's likely that the compliance got worse with time, particularly as we know the trial was done during the height of the COVID pandemic,
Yeah.
which didn't help at all.
So, I'm thinking, even though this would be off-label, but suppose a man comes to me with symptoms and he has pre-diabetes, but his testosterone level is not below 300, but it's below 400, and which is what you have now labeled in the new guidelines, that perhaps this should be the cutoff used if you want to delay the progression of pre-diabetes.
Well, we thought that the evidence was strong enough from T4DM to do that. Should I stop sharing now? Yeah,
You
we
can
thought
certainly stop sharing.
yeah, we thought that the evidence was strong enough from T4DM to do that, but other guidelines haven't. I think in the endocrine world, there's been an unwillingness to accept the findings of T4DM. I think you'd agree with that, wouldn't you?
I would,
Because
yes.
yeah, and I think there's a lot of dogma in that because it wasn't really a message that they wanted to hear. But when you do a study, the results are what you find, and we should stick by them. But even the Australians haven't changed their policy. Their interpretation has more or less been, well, we need to get tougher with the diet and lifestyle, which isn't really what their study showed.
That is true. Now, I hope you can see the slide, the one that I'm sharing on the Androgen Society 8th annual meeting.
Yep.
Melissa, are you able to see the screen?
Yeah, I can see.
Okay, great. Thank you. So I just wanted to remind everyone again that we have our annual meeting of the Androgen Society coming up in just a few days' time. This is Chicago, and it will precede the Endocrine Society meeting. It's a 2-day meeting, 2 full days, June 11th and 12th. There is if I could go back to the chat button. There was a question in the chat, and the question basically was uh, uh, the sorry, let me just bring that. Do we think that testosterone deficiency precedes metabolic syndrome, or is it vice versa?
Well, we both know that the cop-out answer to this is that it's a chicken and egg situation. And I'm going to stick with that answer because a lot of things are chicken and eggs, and it makes it too simplistic to say that the low testosterone will lead to metabolic syndrome because you see it both ways in clinical practice.
That is true. You have someone with prostate cancer, no metabolic syndrome, sudden hypogonadism, and they develop metabolic syndrome. And
Yeah.
then, but certainly most of the obesity that we see is related to diet and exercise choices or genetic choices, not caused by testosterone deficiency. The next part to the same question is, if a man comes with testosterone deficiency and has metabolic syndrome, which should we start with in the clinic?
Which of what? What, testosterone or a PD5 inhibitor? Well, if he's got erectile dysfunction, as I've shown, testosterone is relatively poor on its own at improving erectile dysfunction because erectile dysfunction is more likely to be due to the endothelial dysfunction and microvascular disease than it is to the low testosterone levels. So I always treat with a PD5 inhibitor in a patient with low testosterone who has erectile dysfunction. I never give them the testosterone first and then rely on them coming back and telling me that their erections are no better because the testosterone will improve the sexual desire. And if you improve desire without improving performance, that patient and his partner will get frustrated and they will give up. So I always commence the PDE5 inhibitor at the same time or even before I give the testosterone, because you might be doing, for example, repeated levels, because you don't treat a person on one level, you only treat them when you've had a second or a third level. I start the PDE5 inhibitor right at the beginning because you know they've got erectile dysfunction because you've asked them about it.
I
So
think
this is why I found these figures of 5-8% remarkable for studies that were done over 4 years, when 80% of the patients, 70% had type 2 diabetes and 80% had erectile dysfunction.
the question also was that in addition to testosterone and erectile
Oh,
dysfunction, what
you
about
metformin, you would follow guidelines. I'd use metformin very early.
yeah, and even GLP-1 if possible.
If possible, if they fit the criteria, because certainly in the UK they have to. There are strict, nice criteria, but I try not to raise it because it's very expensive, and I tend not to raise it at that initial visit because of the cost. But if there's clearly a standout reason they're morbidly obese, yes, I would discuss that as well at the time.
Okay. In fact, another question on the same topic, and you can pull up the chat yourself, Professor Hackett, if you
Yeah.
want. But combining TRTs and GLP-1s, someone is asking, is that something we should do more routinely in anyone who collects for GLP?
Absolutely. And every time I go to a meeting on GLP-1s or I read something, I'm looking for somebody to have mentioned testosterone, but the GLP-1 experts aren't even discussing it in the papers. It
Okay.
doesn't appear in the papers. Now, surely when you're talking about fat and lean muscle, you must consider testosterone because it's a vitally important hormone in those parameters. We've always known that. And it just makes so much common sense that if you are an obese patient and your testosterone is 4 nanomoles per liter, then you're going to lose more muscle than somebody who's got a testosterone of 24 nanomoles per liter. But we're not even doing the studies at the moment, as far as I know, to look at this.
Yes. Another question on a different vein. What is your opinion on TRT clinics who have much higher testosterone level eligibility? Example, they will treat up to a total T of 15 nanomoles per higher.
Yes, this is a problem because, but it's the shame is that conventional medicine isn't doing a good enough job. It seems to be acceptable that your GP can say, I don't understand testosterone. He can't say, for example, he doesn't understand HRT because that'll get him into trouble. So it can't be excusable to say, oh, that's too complicated for me. But these patients are therefore being driven to go out and do searches. And the problem with the clinics is that the pricing structure, because what they often do is they give free tests, which cost them money. There's no face-to-face contact. They're done with a thumb sample that comes through the post that you send back. And then if that's borderline or abnormal, you have a second test, which might mean you going to somewhere to get a blood test done. But they don't actually have a base where you can see any of their doctors in person. They've got no clinical base. It's all done online, remotely. And also what we find in the UK is that they're recommending. I talked about the studies that had looked at testosterone undecanoate and testosterone gels. Because they're licensed products, these clinics in their financial model are recommending treatments that are often unlicensed because it fits their financial model better. And that's what I find a little bit worrying as well.
We have often talked about healthy aging, effect of comorbidities, and just normal. So, the next question in the chat is, we would love your opinion on testosterone levels for healthy men versus population average. I mean, perhaps we should all aspire to be in the middle of what a young, healthy man would be.
Yes, I think there are studies that show that certainly from EMAS that there's a sweet spot in terms of longevity, which is round about 14, 15, and we should strive for that sweet spot. But it's very difficult to, even if you believe that, to recommend it without solid evidence base, because it's been hard enough when we've had all these excellent trials that haven't seemingly made much of an impact in terms of cardio prevention and diabetes reversal, to actually go and make these suggestions without good, clear evidence and trials to back it up.
There are no further questions in the chat, but I do have one more of my own, and this is regarding PDE5 inhibitors and its effect on reducing progression to type 2 diabetes. I'm curious as to the possible mechanisms.
Well, the mechanism, as I showed in the it was in that slide. They have prominent anti-inflammatory effects. They through the PKG pathway. We talk about nitric oxide, but there's an alternative pathway. As Graham Jackson said all those years ago, these are important cardiometabolic drugs hijacked by urologists, because as soon as they improved erections, it was a blockbuster drug for pharma industry, and they shelved any ideas that they had for cardiometabolic benefit because of the money to be made from treating erectile dysfunction. And all these years on, we're finding that they're actually very good drugs for what they were developed for in the first place. And I only wish that Graham Jackson was here to still be able to say, "I told you so," because they do improve insulin sensitivity, and they do have anti-inflammatory effects, and they do have tissue healing properties. And the problem is that it's almost like a decathlon drug that has so many benefits that it overlaps so many specialisms that we can't think outside the box of somebody else's specialism.
Nicely put. I don't see any further questions. I will remind everyone again about the upcoming Androgen Society annual meeting. And also that there is a virtual option available. So if it is too late to make travel plans or get away from work, you can certainly sign up for it virtually to have more of this kind of discussion that we had today, and an in-depth review of probably all the topics in testosterone that one would want to know. One more question has popped up, and this is, can we say that PD5 effect is similar to sildenafil designed for pulmonary hypertension?
Well, yes, it's licensed to treat pulmonary hypertension, and it's actually a better drug because of its longer half-life. You only have to give it once a day versus optimally 3 times daily for sildenafil. So yes, it's a better drug than sildenafil for pulmonary hypertension. And I thought somebody was going to raise the question that in pulmonary hypertension with tadalafil we use 40 milligrams a day, and yet there seems to be concern in patients with cardiometabolic disease if you want to go over 5 milligrams. If we're giving 20 to 40 milligrams to fairly sick people, and incidentally including women, because more women have pulmonary hypertension than men, I thought somebody was going to ask the question about Would the benefits of PDE5 inhibitors be seen equally in women as they are in men? To which I believe the answer is strongly yes. And we're trying our best to do a study in women in the UK, but it's proving harder than we thought. So even though I wasn't asked that question, I think it's important because it's often what people are thinking.
Well, somebody has asked a slightly different question. Would you recommend tadalafil as a benefit to generally healthy men, given its benefit?
It depends what you term generally healthy men. I find that the more you look at healthy men, the more you can find little things that make them less healthy. But because for example, at what level do you treat mild erectile dysfunction, mild LUTs? What's bothersome to one man is not bothersome to another.
True.
So some younger men failing sexually once is the end of the world.
Yeah. Very good. Oh, there is another question. Is there an age where you would recommend tadalafil for the average man?
Well, I haven't got experience personally over 102.
But what about a lower limit?
Lower level, well, you're governed a little bit by the product license, but once again, we've used PD5 inhibitors in babies with infants with patent ductus, and we've used it in children with pulmonary hypertension. So the paradox is it's licensed for safety in those age groups if you've got those conditions, which means that we've got a lot of experience of them being taken in younger patients for those problems.
Okay. So there are other words, no definite age restrictions other than the license restrictions in each country.
We've got to bear in mind, we've got to keep to the licensed indications whenever we can.
Yeah, absolutely. Great. Well, thank you very much, Professor Hackett. This was wonderful. And thank you to all the attendees as well. See you guys soon at the Endogen Society meeting. We can log off now.
Thanks very much.
Thank you.